Hybrid physical therapy, transformational zone, functionality, termitology of the transformational zones of pitching mechanics. We have a slew of transformational zones that I've put together as those are pivotal areas that loading, so three-dimensional deceleration and stabilization occur. Those are areas that we assess, evaluate, and treat in because that's where injuries occur at these pivotal loading points. It really gets to the root of the problem for us. And so we take this integrated, holistic approach at function in identifying success as well as limitations and impairments based on one's pathology and or inefficiencies. And so being a physical therapist and applied functional scientist, as I've created these transformational zones, it's pivotal for me to look at the individual as an individual and not as a cookie cutter. And so it's important to consider the timing, the rhythm, the movement skills, previous medical history, the culture and the habits that have created the individual that I'm working with currently. And so I've seen over the last 14 or 15 years, so working in the professional realm for 6 years, a wide variety of compensation strategies unique to the individual. We therefore can't consider a protocol realm like intervention as a solution to correcting everyone's problems. And there's a lot of cases in which we may not have the motion that we want and think that it's a flexibility or mobility issue, and in actuality it's a stability and functional strength related problem. So we want to get to the root of the problem. We want to treat the individual as the individual. We want to look at the transformational zones. I like to go through and look at their video and their game footage first. Take a look at the transformational zones when they get out, and then just grossly taking a look at how they're moving so that I can put together a plan that's customized for them, identifying, hey, this is where the root of the problem is, this is where your success is, let's feed off of that so that we can clean up some of this other stuff. I'm not a pitching coach. I work with a lot of pitching coaches, and I've worked with a lot over the years. And a very common and similar theme a lot of times is that we're so hell-bent on the compliance of mechanically performing something correctly that we undermine, miss, and incorrectly judge the individual's maybe desire or ability to want to change when in fact they just can't. They try as hard as they can, but their body, because of certain deficits and compensations, is unable to do so. And so the goal and the intent of this video is for practitioners, clinicians, coaches, athletes, everyone together involved in the care of an individual that's hurt or not hurt, to be able to collaborate and look at customizing and authenticating the genuineness involved with that individual's ability to use their skill for their enjoyment or for their living and livelihood. So through the transformational zones, because of HIPAA we can't name names, but very extreme differences with regards to stretch and wind up positions of individuals that I've had over the years that have been super successful. And we're not here to highlight those individuals today. We're here to highlight what we need to see in those transformational zones. So the commonality that we have is that the body has to get into those positions in terms of creating that motion. I don't care how they get there, but that they get there, and that's dependent then, or their efficiency, consistency to be able to repeat things, short and long term, is going to be dependent upon their ability to do that in terms of getting into those transformational zones, or zonation as I call it. So we're going to go from the stretch position today. We're going to highlight from and take a look at top-down, bottom-up drivers using the arms and the legs to create motion, and a very scientifically truthful approach and looking at that from some very advanced biomechanical sequencing. Truth is truth. Truth doesn't change, but a perspective of it does. There's a lot that is used to be able to kind of sell parents, coaches, and athletes today in certain anecdotal, guru-like fashion, a certain approach that, hey, everybody has to do it this way, and I don't believe that's the case. We need to look at the movement movement IQ of an individual and regenerate an updated and revised blueprinted system, update the software to the GPS system to give that individual better control over their DNA and genetic potential. TZ1A, we're just going through the stretch position today. We're not messing around with the windup, hybrid windup, or a slide step position. But in a TZ1A position from the top down, okay, what's going on? What's driving what? We're on a slope downhill towards home plate and the hitter. The heel is in a position, the rear foot and the entire foot's in a position which it's rotated, position versus motion towards home plate. Well, as soon as my lead side leg comes up and off the ground, I have this top-down driver from the left pelvis to the right that creates internal rotation of the right posterior lateral pelvic girdle. I get the motion of posterior rotation of the pelvis at this point in time with some adduction of the right hip as I'm closing up this angle at the right hip. So I have this top-down driver in which the pelvis is rotating to second base faster than the femur. Relative motion is what we refer to as joint motion. Distal segment in regards to the proximal, which ones, so it's what the distal is moving in regards to the proximal. So the pelvis is rotating faster, which gives us internal rotation. Real motion is our bone motion, what the bony segments are doing in relation to each other. Well, I get internal rotation then of the right knee because the right femur is rotating with the faster than the tibia and the fibula. The tibia and the fibula grab the talus as well as the calcaneus, externally rotating it, so adducting it in the frontal plane towards second base. That gives us relative adduction and relative eversion at the mid-tarsal joint, with inversion at the subtalar joint. This motion and position of kind of locking out the mid and the rear foot are kind of this distal stability for proximal mobility kind of factor and acceleration, and that we get a good stable anchor point of motion that we've created at the rear foot and the midfoot that really allows us to wind up the posterior and the lateral pelvic girdle complex, which is the joint capsule, as well as the gluteal complex. Top-down like effect of the thoracic spine based on what the glove and the throwing side arm are doing gives us some right rotation, which further down loads up the butt and the hip. We get relative left rotation of the cervical spine and side bend, so a type 2 motion that's taking place with the cervical spine. There's a lot going on with the cervical and thoracic that we'll get to. So TZ1A is going to take us through what we call transformational zonation 1A and 1B to our TZ1B position. And that'll take us to a TZ1C, which then TZ2 is everything involving the body's deceleration post instantaneous point of releasing the baseball. So TZ1A, as I transition on out, my lead side leg and my glove side arm become incredible top-down drivers, respectively and relatively speaking, into the right hip and the right lower extremity. As I'm transitioning with the left foot down back towards the ground and out towards home plate, I'm getting this tremendous load of right hip flexion, so an anterior rotation of the pelvis, adduction and internal rotation. So I've wound up the transverse plane and I'm continuing to decelerate that motion, and then further in that load in the sagittal plane with hip flexion and adduction as my rear foot is starting to evert, giving us eversion at the subtalar joint, which is giving us relative abduction, so an opening up of the midfoot and the rear foot, and relative inversion, so midfoot and rear foot right here. It's giving this unlocking effect in which we get to absorb the contour and shape of the ground as I transformalize into TZ1B, so that I eventually have something very solid to push from. The transformational zones is all about this teeter-totter-like effect of creating motion in the opposite direction, shifting through motion, other planes, so I'm winding up these mechanoreceptors and taking advantage, proprioceptors of stretch, compression, and tension, furthering the disassociation throughout the entire body. This is like cars driving on a highway. If everyone's driving at the same speed at the same time, we relatively speaking get no motion. That's when we start to get an unraveling from the top down rather than the bottom up. Bones in the body need to be moving. They can be moving in the same direction, but they have to be moving at different speeds and at different times to give us motion at the joint. Otherwise, we're going to start to see our pathological conditions within the shoulder, elbow, and the low back, which are very pivotal areas throughout our system today. Big areas that we're focusing on are foot, ankle, hip, and thoracic spine. Areas that have a ton of mobility accessible to it are areas that are going to get gunked up and compensated quite readily. So as I'm transitioning down into transformational zone Asian 1A/1B, this top-down like glove arm driver is starting to give us a type 2 out-of-sync motion of the thoracic spine, which I get a right side bend and a right rotation as I start to unravel from the bottom up quicker than the top down. So as I'm transitioning into this motion, the butt is going to be responsible for controlling the adduction of the femur. So the femur kind of collapsing down and in, tipping the fibula abducting, giving us this gapping, this abduction at the right knee, as well as internal rotation here. So the tibia and the fibula are going to be rotating towards home plate faster here than what the femur is. Posterior lateral glute complex, hip complex need to be able to be stable, strong enough to be able to control that. And so it's at this point in time that as I'm also in that adducted hip frontal plane position, creating that motion, I get to a point then where I'm adducted, but I'm getting abduction. So the single leg anterior reach kind of driver, which is medial, continues to further the load of the right hip and butt, as well as the right foot and ankle, and the thoracic spine from the top down with the glove side arm here. And so as I'm transitioning on out, I'm getting the abduction of the right hip. I get a relative left rotation and left side bend of the cervical spine, in which the cervical spine or thoracic spine are gummed up. We're not going to get that motion. So we could have a really gummy degenerative cervical spine, scapulothoracic joint that's having a big effect upon the thoracic spine and its motion, as well as the hip. And TZ1B, so from the top down we have this glove side driver, the cervical spine driver of left rotation and left side bend. That's giving us this type 2 out-of-sync motion throughout the thoracic spine of right side bend, right rotation. From the bottom up, we're unraveling faster. We get right hip abduction, extension, and internal rotation. As here, femur is rotating a little bit quicker in the transverse plane than what the pelvis is. We get this anterior lateral to the left slide and glide of the pelvis on the femur, which is actually what's allowing us to get in effect with the thoracic spine. This extension and abduction, we're slowly loading up the left hip complex, posterior lateral into hip flexion, adduction, and internal rotation to get us to TZ1C. So we get this bottom up driver that's quicker from the bottom on up. We're starting to transition from eversion to some inversion at the right foot and ankle complex to give us something firm and solid to be able to push from. So foot still parallel with the rubber in this position, and that's getting us to the point in which we then get to a TZ1C position. But from 1B to 1C, we have this tremendous body on arm loadability taking place that's actually creating motion at the scapulothoracic joint. So as I'm transitioning on out from 1A to 1B, it appears a lot of times that the arm is going up into this upperly rotated, abducted position, which there's obviously some involvement there. But this type 2 motion of the thoracic spine with its right side bend and right rotation is actually creating the eventually kind of the external rotation, the retraction, and the upwardly rotated position that we get into that allows us to create more retraction and more posterior tilt with the thoracic spine extension, with the right hip extension, abduction, and internal rotation.